clinical diagnosis of PAD, which by the time they get to the specialist's office, they've usually seen their primary care provider or they've seen another specialist, and they have determined that they think that this patient may have claudication. So really, for me, before I even look at the ABI or before I do anything, I take a history. And the classic things that I'm looking for is the history of a classic history of muscle pain with walking that's reproducible day in and day out, and that is relieved by rest, and the patients can go on. And because patients, as they get more elderly, will accept the fact that they have more and more disability, many of them will tell you that they've had PAD symptoms for many years before it actually comes to fruition to a clinical problem. So taking a history. So fine, you find out about their symptoms, maybe now they have a wound on their foot, but then the other things are, what about their risk factors? And we're going to go into that in just a second. Because the risk factors are pretty classic. Hypertension, diabetes, smoking, hypercholesterolemia, family history, sedentary, obesity, all of the things that you all know. And then you always want to differentiate your patients in peripheral arterial disease. You want to differentiate your claudicators from your critical limb ischemia. So anybody that has a wound, ulceration, gangrene, things that are not healing, you've got to be sure that they don't have critical limb ischemia. So how do you do that? You take a history and you examine the patient and you ask about night pain and rest pain, and then you examine them. So what about examining them? So, you know, all kinds of feet show up in the office. This is a particularly, you know, this is sort of Monday morning thing that turns up in my clinic. The patient says, oh, I got a little sore on my foot. You take off the shoe and sock and you see this and you go, oh. It's pretty obvious that they've got a problem, all right? But what about the more subtle ones? Well, sometimes it's about the temperature of the feet. Sometimes it's a little bit, if they're diabetic, they may actually have good perfusion, but they have poor sensory function. So what about checking their sensation? What about their motor exam? Do they have actually some motor dysfunction? And then, although I spend a lot of time on a pulse exam, the fact of the matter is for many diabetic patients, they actually don't have peripheral pulses. So you've got to recognize the subtle signs of critical limb ischemia, and if you can't feel a pulse, get out a Doppler. And that goes if you're in the emergency room or even if you're a primary care provider. Now, I picked this up because quite often the patients in my clinic are sitting there and their feet are exposed and they're sitting there when I walk in. And so the top left, you see a picture of somebody's feet. And what you see there is that both feet look a little rubrous. The right one looks a little worse than the left. And so an easy non-invasive thing. Lift up their feet, you can see in the middle picture, both feet have turned white, although there's some fixed staining of the first and second toe on the right foot. And that close-up picture shows the guttering of the veins, these empty veins. There's so little blood flow that those veins are not filling. And then you can put the feet down, back into the original position. In the left upper picture, you see the two white feet after you put them down. But notice, in the bottom left, you can see that the left foot is now getting pink. It's reperfused, but the right foot significantly delayed. And in the top right, you can see now the right foot is getting reperfusion because of gravity. And there you see what the foot looks like after a couple of minutes. So that's a pretty easy test that you can do in the office. It takes about 2 minutes, and it gives you a pretty good idea how bad their perfusion is because that person's got critical limb ischemia. So once you've made a clinical diagnosis, what are the Doppler criteria? Because everybody's heard you should do an ABI on these patients. And frankly, ABI, even in Ontario, is poorly reimbursed and it's poorly done as a general rule. But the ABI is the highest ankle pressure over the highest arm pressure. And so the definition of PAD in many studies is an ABI less than 0.9. The problem with that is that in your diabetic folks, you're going to get, people are going to tell you that they're calcified. And that's a very common thing, so that we have to do either toe waveforms or toe brachial index, and I'm going to show you a slide about that. So our diagnosis, ABI is the classic, but in Ontario, I can tell you it's so poorly reimbursed, you usually get a peripheral arterial study with that, which includes Doppler waveform analysis of arterial waveforms, which you see in the upper left-hand corner. There you can see that's a common femoral artery. It's dividing into the superficial femoral and the profunda, and there's really nice laminar flow. And in the top right, you see the arterial waveform that the technician has displayed for you. And notice it's a nice triphasic waveform. Well, that's up in the femoral. In the bottom right, you see a very monophasic waveform down in that patient's dorsalis pedis artery. And the fact of the matter is that indicates that between the top of the leg and the dorsalis pedis or the posterior tibial, there is substantial occlusive disease, because if there was no substantial occlusive disease, you'd have transmission of that triphasic wave all the way down the leg. So an arterial duplex, in addition to an ABI or a toe brachial index, is something that helps you not only identify the disease, quantify the disease, but it localizes the areas of stenosis and helps us decide on treatment. Now, sometimes you'll see people do segmental pressures. We don't do segmental pressures, we do segmental waveforms. But I put this diagram up because you can see the little blood pressure cuffs on the big toes there. And notice that the left foot has a wound on it. And there's a plethysmography cell there on the toes. And so they're blowing up those cuffs on the ankle, and they're getting an indication of how severe the blood flow reduction is at the tip of the toe. So if you look on the right side at the bottom, there's quite a good arterial waveform in the big toe, whereas the left big toe has a very flat arterial waveform and is very monophasic. So there's the indication that you've got severe distal disease in this particular patient, because up at the top of the leg, you've got very good flow. So you've localized the disease, and that's going to help us in terms of our treatment. So why are diabetics and peripheral arterial disease such a terrible combination? Well, first of all, if you look at all of the PAD population, there's a high representation of diabetics in there. And the prevalence of PAD in diabetics is extremely high as 40% in some series. It's increased particularly in America and African American and Hispanic individuals, but in Canada, Indigenous peoples have an extremely high rate of diabetes in the male Indigenous population, and the complications of diabetes in terms of the arterial occlusive disease that they get is substantial. In patients with diabetes, they tend to get more small vessel disease. They get more tibial disease, more disease in their plantar arch, more disease in their popliteals. And so that actually makes revascularization sometimes a little more challenging, because you're dealing with the smallest blood vessels in those patients. Now, diabetes, of course, is the most common cause of non-traumatic amputations in America as well as in Canada. It accounts for about 60% of cases. And our job really is to try to keep these people's feet on, and that encompasses not only treatment of their PAD, but also things like foot care, proper footwear, and rapid access to wound care once an ulcer develops. So the second thing I'm supposed to talk about after diagnosis is really medical management opportunities for patients with PAD. Now, if your patient is a diabetic, it stands to reason they need treatment for their diabetes, but the fact of the matter is that these patients usually have major cardiovascular comorbidities as well. And what you're starting to see in major cardiovascular therapeutic trials is that they're starting to enroll PAD patients because the cardiologists have finally realized that those patients have much more advanced atherosclerosis than some of their patients who just have coronary artery disease or stroke alone. And so risk reduction strategies are using, instead of just the MACE as the major adverse cardiac events, they now have a term MALE, major adverse limb events. And so you're starting to see this as an endpoint in large clinical trials for secondary prevention. So what's the definition of MALE? Well, if a PAD patient develops acute limb ischemia. In other words, they go on from their chronic limb ischemia, and now they present with acute limb-threatening ischemia. They've got a definition there, patient who needs intervention within 30 days for an acute arterial event, either a radiological criteria or a new pulse deficit leading to an intervention, or a chronic PAD patient that requires an intervention, or somebody that requires a major amputation, not just a digital amputation, but an AK or a BK. So that's the definition of male. You may be familiar with MACE, but male is kind of new on the horizon. Now, what about the medical management of PAD? So anytime I see any patient with peripheral arterial disease, you actually have to do a comprehensive assessment on them. You need to know all of their cardiovascular risk factors. Some of them are pretty apparent when you just look at the patient. They've got the brown stained fingers. The belly is hanging over the belt. All right? You ask them about what their medications are. Well, they've got their own 3 blood pressure meds. You find out, oh, I just found out I had diabetes a year or 2 ago. Are you taking your meds? Well, my sugar is not that great. You have to go through all of these things in a vascular clinic because your patients have them, and as a general rule, they're not that well, sometimes they're not that well managed. And of course, what do they know about their cholesterol? Is their cholesterol or their lipids well managed? What about, and what sort of therapies are they on? Are they on antiplatelet agents? Are they on antithrombolytics? Are they exercising? Are they doing the proper diet? And what I've put down there in terms of medical management are things that are generally evidence-based. We all know that smoking cessation may not make a short-term difference, but it makes a long-term difference. Managing their obesity. Hypertension treatment for diabetics, the Canadian guidelines are 130/80, whereas for non-diabetics it's 140/90. Obviously, you want to get your hemoglobin A1C less than 7. You want to get a good fasting glucose if you can. Managing their lipids to get their LDL less than 1.8. They all should be on antiplatelet agents. As you know, antithrombotic agents are now indicated for a chronic PAD. You want to get them exercising. And it's been shown that a diet rich in fruit and vegetables is better for them. So how well can you do at risk reduction? So I put down, this is a paper that I did with a number of the fellows in Toronto. And this started about 2014, and that's when risk reduction for vascular patients became an important thing. And so we set up a program in our clinic where patients who had PAD, we assessed not only their vascular risk factors, but we did laboratory investigations, and we looked at their meds. And we gave them an educational pamphlet. We gave them an individual letter about what their lifestyle goals should be, about smoking cessation, exercise, medications. We wrote a letter to their family doctors saying what the clinical guidelines were in place and the rationale for the therapy that we prescribed, and we gave them their laboratory and clinical targets, and then we followed them up. The problem was when we followed them up, we didn't have a control group because this was just an intervention that we did. So we went to the Institute for Clinical Evaluative Sciences and were able to do a propensity matched analysis. And here you can see we matched our PAD patients, 290 of them, to PAD patients that had been seen by vascular surgeons around Ontario. And basically, if you look in these couple of slides, you'll see that what happened was we didn't have a big impact on body mass index, but we had an impact on smoking, we had an impact on lipid, we did not have an impact on their diabetes. We had an impact on antiplatelet agents, statins, blood pressure control, and there was a significant impact. So you'd ask, well, did they survive any longer? Well, in fact, the SAVOR patients, which is what we call our program, is the yellow bar. There was a significant reduction in acute myocardial infarction, ischemic stroke, and cardiovascular death in those patients, and it was sustained. And if you looked at other factors, major, minor amputations, there were fewer major and fewer minor amputations. We also did less bypass surgery than our colleagues around the province, but interestingly, we did more angioplasty. So risk reduction does work, and it's something that every primary care provider or every vascular surgeon can do. So, in conclusion, early recognition of PAD, especially in diabetes, is critical to improve outcomes. The key PAD risk factors are all very well known to all of you. Patients usually know them, they just need somebody to tell them they've got to start managing them. And major trials are looking at both MACE and MALE as outcomes, and you're going to see those in major trials. And I've shown you that risk reduction therapy, it's effective. If I can do it, all of you can do it. And new therapeutic modalities, both either in the treatment of PAD's complications or in fact in risk reduction, will help prevent limb loss, which I hope I showed you through the data that we presented. Thank you very much.